If you're still struggling to get a good night's sleep, but your sleep doctor tells you that you don't have sleep apnea, then you must watch this video. I'm going to describe why upper airway resistance syndrome is the most ignored sleep condition and what you can do about it so that you can start to sleep better and wake up refreshed and feel alive again. Hi, I'm Dr. Dr.Park. I'm an ENT surgeon and sleep physician. I'm also the author of the Amazon best-selling book, Sleep Interrupted. This book describes my personal journey on how I came to discover upper airway resistance syndrome, both for myself and my wife as well. This is what led to my sleep breathing paradigm concept. I highly recommend reading it. I'll place a link at the bottom description area. Obstructive sleep apnea has been described in up to 10, 20, or even 50% of certain sex and age groups, and this is based on either questionnaires or formal sleep testing. And we know that untreated, moderate to severe apnea can raise your risk of diabetes, high blood pressure, heart disease, heart attack, stroke, cancer, car accidents, and sudden death. Shockingly, it's estimated that 80% are not diagnosed or treated. But what if I told you that UARS is much more common than sleep apnea? But essentially, it's a lesser severe version of sleep apnea where you have breathing pauses that are caused by partial obstruction and you wake up much quicker so you don't have lack of oxygen during the episodes. But what ends up happening is that you get frequent microarousals and sleep fragmentation. So let me explain what UARS is by describing what sleep apnea is. On the sleep study, apnea means that you stop breathing for 10 seconds or longer with completely obstructed breathing. So there's no airflow here, but you have effort and movement in your chest or abdomen. Another technical term is something called hypopnea, where you have partially obstructed breathing. So this is normal breathing in a sine wave, but with hypopnea it only goes up partially. So if these episodes last for more than 10 seconds and you have your brain waves waking up or your oxygen drops more than 3 to 4%, then it's called hypopnea. But again, for both apnea or hypopnea, it has to be for more than 10 seconds. And finally, to have a diagnosis of sleep apnea, you need at least 5 apneas or hypopneas per hour to say that you have sleep apnea. That's mild sleep apnea. But let's say that you stop breathing 25 times an hour for only 9 seconds each. By definition, you don't have any apneas or hypopneas. Your score is going to be 0. But notice that you still stop breathing 25 times an hour, but there's no lack of oxygen as a result. However, it does fragment your sleep, causing your brain to wake up 25 times an hour. So basically, you get diagnosed with UARS if you don't officially have sleep apnea, so it's a diagnosis of exclusion. And on the sleep study, basically you don't see very much. You may have lots of arousals and sleep fragmentation, but the apnea-hypopnea index and all the breathing parameters are relatively normal. So UARS ultimately leads to unrefreshing sleep. So these are the typical symptoms of UARS: severe chronic unrefreshing sleep, chronic daytime fatigue, headaches or migraines, anxiety and depression, poor digestion or IBS type symptoms, irritable bowel syndrome type symptoms, sinus pain and pressure, dizziness, skin problems, brain fog, memory problems, hormone imbalances such as low thyroid functioning or low testosterone or estrogen or progesterone, or for women, exaggerated symptoms during periods or during menopause. So why do I say that UARS is more common than sleep apnea? Think about the last time you had a cold or an allergy attack. You probably didn't sleep well at all, tossing and turning at night, right? What happens in this situation is that swelling and inflammation leads to narrowing of your nose and your throat, and this leads to partially obstructed breathing. So think about breathing through a toilet paper or a paper towel holder tube versus a regular straw. Which one would you like to breathe through at night? So think about breathing through the paper towel tube as being normal, but breathing through the straw describing UARS. So think about various life situations where the airway gets narrowed temporarily or permanently, such as due to colds or infections, allergies. You can also have large tonsils and adenoids. Your nose can be stuffy for any reason. And also you can have excessive dental extractions, especially with headgear that pushes the jaws back. Weight gain due to enlarging fat cells in your throat and your tongue. And also before women's monthly periods due to low progesterone and more tongue muscle relaxation. And also gradually lower progesterone and estrogen levels in perimenopause. You can also have cold hands and feet, which is very common, and low blood pressure. And blood pressure tends to be on the low side with dizziness and lightheadedness when standing up too quickly. Repeated negative pressures in the chest cavity and the throat also leads to acid reflux. It's also been found that stomach reflux contents can also reach the middle ears, the sinuses, and down into the lungs. It's not only acid, it also includes digestive enzymes such as pepsin, as well as bacteria, and even lipid-laden macrophages. The classic study that first described UARS was by Dr. Christian Guilleminault at Stanford in 1993. He looked at young and healthy men and women who didn't officially have sleep apnea on the sleep test, but they were very tired. So they did this sleep test again with a pressure sensor in the middle of the esophagus about here. And what they found were lots of episodes of severe negative pressure with each breath in, leading to subconscious awakenings every few breaths, all without a drop in oxygen levels. What you see is that the obstructions get more severe and last longer and longer. With time over a period of years, what you see is that the obstructions get more severe and last longer and longer. It's actually thought that the protective reflexes in the throat that senses negative pressure and also acid become less and less sensitive due to chronic overstimulation. So your natural responses to an apnea or acid in the throat takes longer to react. What Gimeno also calculated was that about 13% of people with the UARS go into sleep apnea every year, especially if you gain weight. What also ends up happening is that this creates a chronic state of physiologic stress with the cortisol levels going up and your thyroid and sex hormones going down. This also diverts your blood flow and energy away from your digestive and reproductive organs to your core muscles so that you can run or fight. Your hands may also seem cold all the time as a result of blood being shunted. As you can imagine, all of us go through some or many of these life events or transitions, and all of these will ruin your sleep either temporarily or permanently. Only if the sleep problem becomes more common or permanent does someone see their doctor at all. Oftentimes, they're not going to see their sleep doctors because the signs or symptoms don't seem to be sleep related. And most people with UARS are relatively younger and thinner, and slightly more women than men. And as I mentioned before, as you gain weight, you'll go into sleep apnea from UARS. And this happens quite often when women go through menopause. They had severe UARS when younger, but then they have sleep apnea after menopause. So what can you do if you think you have UARS, but your sleep study says you don't? Essentially, the same steps for treating sleep apnea also apply for UARS as well. But if you don't have an official sleep apnea diagnosis, then nothing is covered by insurance. However, if you have nasal congestion or large tonsils or adenoids, these will be covered since they are different diagnoses. So here are my 9 general tips for treating UARS. You'll see that it's almost identical to my list for treating sleep apnea. Number 1, no eating within 3 to 4 hours of bedtime. By definition, whether you have sleep apnea or UARS, you're going to have reflux, and this causes nighttime arousals and fragmented sleep, and even more apneas. Number 2 is a fully optimized nasal breathing, starting from conservative options to even considering surgery by an ENT if necessary. I can't emphasize enough how important it is to have a clear and open nose so that you can keep your mouth closed. Not only does this allow CPAP and dental devices to work better, but keeping the jaws closed opens up the airway behind the tongue. And number 3, try mouth taping for the reasons stated in number 2. I'll place a link to the mouth taping video below. Number 4, don't sleep on your back. Problems may start if you're normally a side or stomach sleeper and you're forced to sleep suddenly on your back due to an injury or after surgery. Or even after your dermatologist told you to avoid sleeping on your side or stomach to prevent wrinkles forming on your face. This is a really bad idea. Keep doing this and you'll get even more wrinkles on your face since your sleep quality will go down. Number 5, see a dentist for a mandibular advancement device. This is typically given for snoring and mild to moderate sleep apnea. Number 6, try CPAP or APAP, or continuous positive airway pressure, and APAP is automatic positive airway pressure. If you don't have sleep apnea, you may need to buy one out of pocket. You'll also have to get additional supplies such as the mask, headgear, and tubing. And you'll need a prescription from your doctor to order one. I have to warn you that with few exceptions, service from the CPAP equipment companies and the sleep labs is not that great. So if you choose to try CPAP, take advantages of all the resources on my website and my book, Totally CPAP, and I'll place the links below. There are also lots of other great online resources for new CPAP users. Number 7, talk to your dentist about possible palatal expansion or a functional expander. For children, one important study to think about is that palatal expansion was found to be equal to tonsillectomy in terms of curing sleep apnea. Number 8, oral surgeons also offer various types of surgery-assisted palatal expansion. And you have to remember that palatal expansion of any type does a good job of expanding side to side, but does very little to pull both your upper and lower jaws forward. And lastly, number 9, consider jaw surgery, especially if you tried everything else. Since the main reason why you have UARS is because your jaws are small, whatever you can do to enlarge your jaws in 3 dimensions is most ideal. As you can see, the reason why UARS is ignored is purely based on the outdated sleep study scoring criteria. The good news is that it's treatable, but only if it's recognized to begin with. I hope you found this information helpful. If you think you may have UARS, go through the checklist. If you already tried some of these options and want to dive much deeper into how you can improve your sleep quality, then I invite you to consider signing up for a virtual coaching session with me, Click above or in the link below for more information.